Hello and welcome to another episode of Hema Now, our haematology podcast series. I'm your host, Dr. Jonathan Sackier, and in each episode, I have the pleasure of speaking with leading voices in the field of haematology. Today, I'm delighted to be joined by Dr. Lydia Scarfò. Since 2012, Dr. Scarfò has been based at the San Raffaele Scientific Institute in Milan, where she's deeply involved in both preclinical and clinical research. She currently serves as co-investigator on more than 20 clinical trials focusing on chronic lymphocytic leukemia and related disorders, including several early phase studies. Stay with us as we discuss her path into hematology, the evolving landscape of chronic lymphocytic leukemia research, and the future of precision medicine in lymphoid malignancies. It's a real pleasure to have Dr. Lydia Scarfò on the podcast. So, Dr. Lydia Scarfò, lovely to have you here with us on the podcast.
Thank you so much for having me. My pleasure.
You're welcome. So let's begin with a few questions just to kind of cut the ice and get to know you a little bit better. What's the most surprising thing that you've ever learned from a patient?
It was actually something the husband of one of my first patient told me. He said once, because unfortunately his wife, it was ages ago, she died due to chronic lymphocytic leukemia. And he said, I recognize the happiness by the sound it made while living. That is a quite famous quote from a French poet, Jacques Prévert. But it made me think how we should appreciate and value even the small thing we have in our everyday life while they are there.
Yeah, last night I received a text from a friend in America asking for some advice. One of his close friends, I don't know this lady, her mother just had a stroke and has probably already passed away. And there was sending photographs and saying, but we were just out at dinner last night and she was fine. We all need to do that, don't we? We need to find joy in every aspect of our lives. And certainly as doctors, I always think that's one of our responsibilities. So during long laboratory days, what do you do to keep focused? I have ADHD. My mind is always, oh, look, squirrel. What do you do to keep focused, or what do you look forward to for when you're not working?
I have to admit that I'm a sort of workaholic. I really like my job, and besides the research activity and the lab activities, I'm very keen on time spent with patients. So I really like my clinical hours in the outpatient clinic. And I'm very much looking forward while when I am at home to learn from the latest update from the literature in the field in order to improve my everyday clinical and laboratory practice. And of course, I like to spend time with my friends, and I'm living in Milano, Italy, so I have plenty of opportunities of enjoying several aspects.
It is a great city. And I'm always reminded that nowadays, when people are so keen to talk about burnout, yes, our jobs can be very demanding, but I think we're the most privileged people in the world. We have a job where we are constantly learning, constantly mentally challenged, and at the end of the day, we're doing things to try and help people. So I'm with you. I love medical terminology, Lydia. There's one phrase I remember when I first heard it at medical school, hypertrophic pulmonary osteoarthropathy, and the combination that you can have a lung disease and a bone disease, and the two are combined, and you have these wonderful long names. Have you got any medical terms that make you smile?
I like a lot to use the term synesthesis. That means the overall sense of being alive and in a state of well or ill being. So I
Love it. I love it. So, again, on this theme, if you had to explain leukemia to a 5-year-old or just a simple surgeon like me, how would you do it? What would you describe leukemia as?
I would say that is an uncontrolled growth of our immune cells that instead of protecting our body, they are trying to destroy it.
Yeah. You know, in these days of social media where everybody is an expert and everybody is a journalist, I always think that as doctors, we have a profound opportunity, actually a responsibility to communicate. That's a nice definition. I'm going to keep that. If you had a superpower related to your work, what would it be? I mean, something like you could just look at a long list of lab results and instantly interpret them and build a picture. I have to go very slowly. That would be a superpower I would love.
I would go for mind reading because this way I can understand what the patient thinks and try to be more helpful and go to the point they sometimes do not dare to discuss.
Right. Yeah, they sometimes don't tell us what's really on their mind. Now, I love rare disease. I'm fascinated by rare diseases, um, and things like Gaucher's and Fabry's disease, and these sort of conditions. What's a lesser known blood disorder that you wish people knew more about because it fascinates you?
In general, I'm working in the field of B-cell lymphoproliferative disorders, and I think there is not very much awareness of the indolent form of lymphomas. They are less well known. So I would say, for example, hairy cell leukemia, this is an extremely rare B-cell disorder. It's something people don't know about, but it would be relevant to include this disease in the potential differential diagnosis of many clinical conditions.
Wonderful. Again, I think those of us who aren't in your specialty, we have a disproportionate view of the incidence, the prevalence, and the severity of various conditions. So thank you for that. All right, well, let's dig into some meatier questions. Your research, Lydia, predominantly focuses, as you said, on B-cell lymphoproliferative disorders. Take us through what led you into this specialty.
I mean, what I really like is that in indolent B-cell lymphoproliferative disorders, you get to build a physician-patient relationship, meaning that these are chronic disorders, so you follow the patients over time. Sometimes they do not need treatment, they just need to be assessed on a periodic basis with lab tests and physical exam. So I really like that you follow the patients over time and you are able to build a strong relationship with many of them. This is what I found very interesting and very fulfilling in this job.
One of my colleagues when I was working in Washington, D.C., was a hematology oncologist. I don't know if he'll be listening in, but Craig Hankins, lovely, lovely guy. And he told me that what he loved was the fact that it went from laboratory medicine to clinical medicine to acute medicine to chronic. So you were looking at down the microscope, you were correlating what you saw with the patient's symptoms, you were managing them in the acute phase, and then hopefully managing them in the chronic. It really is a very unique combination. So in March of this year, you published a paper that explored the role of the STIL gene, which I believe sits on chromosome 16, because I'm useless with dermatology, but I know it also codes for a nasty multi-tumor skin disease. So, but SILD is a key tumor suppressor in splenic marginal zone lymphoma. Can you walk us through how SILD loss alters the behavior of these cells and what this might mean for future therapeutic strategies?
So it was an effort focused on, as you mentioned, trying to understand better the pathogenesis and the outcome of splenic marginal zone lymphoma, that is a very rare lymphoma, is less than 2% of all lymphoid malignancies. And it follows a very heterogeneous clinical course, is generally very indolent, but then when it comes to requiring treatment, it might be difficult to identify an effective treatment able to achieve long-term disease control. So we focused on the role of SILD, that is acting generally as a tumor suppressor gene. So it's down-regulating the activity of a key pathway, NFKB, that is crucial for the survival and proliferation of splenic marginal zone lymphoma. And we found that the loss of SILD is associated with a more aggressive clinical outcome of patients with splenic marginal zone lymphoma. And this is explained by the activation of the BCR pathway, and in particular of the NFKB pathway, leading to increased proliferation and mobilization of the cells from the tissue into the peripheral blood and in different other sites. And this is also associated with potential resistance to ibrutinib, that is a covalent inhibitor of BTK that is used at clinical level in patients with splenic marginal zone lymphoma. So we thought that this might help us in the next future to identify other potential targets that can overcome ibrutinib resistance and provide other effective treatment options for patients with splenic marginal zone lymphoma.
Right. For the benefit of those of us who know nothing about splenic marginal zone lymphoma, give us a definition from 30,000 feet. You said it's very heterogeneous in its clinical presentation, but give me, like you said, you're explaining to a 5-year-old what leukemia was. Give us
It's included in the group of indolent B-cell malignancies because it generally follows, as mentioned, a quite indolent clinical course. It is generally diagnosed because of the occurrence of increased spleen size, so splenomegaly. Generally, it does not require treatment at the time of diagnosis, but once the disease is diagnosed, we should follow patients over time because at some point they can develop disease-related symptom or signs. And we have therapies available for this kind of lymphoma, in particular anti-CD20 monoclonal antibodies and covalent BTK inhibitors. They work, but we want, of course, to identify other potential treatment options, especially in those who become resistant to available treatments.
Right. Okay. Thank you for that. So you recently spoke about moving away from chemo immunotherapy for chronic lymphocytic leukemia and utilizing novel targeted therapies more. Can you share what's driving this shift and how these newer treatments are changing the landscape of CLL management for both clinicians and of course, patients?
Thank you, because I think this is a very important point for the discussion. I'm focusing my clinical and research activity, as you mentioned, on chronic lymphocytic leukemia. That is actually the most frequent adult leukemia in the Western world. And in the last few years, we have seen great advancement in the treatment of this disease. Because as you correctly mentioned, until few years ago, we only had the chemoimmunotherapy available, and we didn't like the chemoimmunotherapy options because they were associated with long-term adverse events, and they could not achieve long-lasting disease control in a relevant proportion of cases. So in the last few years, several so-called targeted agents, meaning drugs that work by targeting specific mechanism of the leukemic cells, became available in everyday clinical practice. First, the covalent BTK inhibitors. We have now several different covalent BTK inhibitors that are targeting proliferation of CLL cells. and reduce the survival of CLL cells, also by detaching them from the supporting microenvironment. And the other key drugs that recently became available are the BCL2 inhibitors. So we have venetoclax currently available, and they can be used in the treatment of chronic lymphocytic leukemia, either together, these two class of drugs, or sequentially, in order to achieve long-term disease control. And when I started working with patients with CLL, as mentioned, we had several type of chemoimmunotherapy, but the most effective ones basically could not be administered in the majority of patients because they were too intensive, and they were meant only for young, fit patients. While these novel targeted agents we now gained in our therapeutic armamentarium, they are generally well tolerated and can be effective. And now we shifted from administering them in a continuous way, that was our first strategy in this setting, to combining them in order to define fixed duration schemes that can be administered for a while, and then patients can go to, let's say, treatment holidays, because they are defined as time without treatment when the patient is enjoying a normal life, let's say.
Yeah. And important to communicate this to patients because certainly in my lifetime, the diagnosis of one of these dyscrasias was a death sentence. And because of the work of folks like you, it isn't. And you can convert these very nasty diseases into chronic diseases. And there are a range of other options. And that must be so immensely satisfying for you and obviously wonderful for the patients, right?
And in this regard, you are absolutely right, because recently we were able to demonstrate that patients with CLL treated with these novel targeted agents had actually the same life expectancy of general population, same age and same gender. So this was a very reassuring message, and it's full of hope for the patients and for the physicians taking care of patients with CLL.
Yeah, wonderful. So you've mentioned ibrutinib, covalent BTK inhibitors. They've shown great efficacy, but are also associated with cardiotoxicity in some patients. What strategies do you recommend for managing that risk while still ensuring patients receive the most effective treatment possible? Obviously, always balancing risk and benefit is key. Can you address that?
This is a very relevant point. As you said, covalent BTK inhibitors as a class are generally associated with potential cardiovascular toxicity, the most frequent one being atrial fibrillation and hypertension. So what we generally do is we perform a cardiac workup before starting treatment, because I mean cardiac comorbidities are very frequent in the general population, but we have made great progresses also in the treatment of cardiovascular diseases. So in our practice, we generally perform an ECG and an echocardiogram in all patients, regardless of the treatment strategy before starting treatment. And then if we identify poorly controlled cardiovascular condition, we refer the patient to the cardiologist in order to optimize the cardiovascular disease control before starting treatment. As you said, this is not to exclude patient from receiving an effective treatment, but just to optimize the clinical condition before starting treatment, so that they can receive the appropriate treatment for CLL, and hopefully they don't experience relevant toxicities.
Okay. So you've mentioned hairy cell leukemia, and we've talked about chemo-free approaches. You're currently serving as the principal investigator in a study exploring a chemo-free approach for hairy cell leukemia. Can you share any recent updates or insights from the trial and what this could mean for the treatment of this disease in the future? Well, and what was the philosophy in taking this approach?
I mean, I'm very excited to be involved into this trial because I think it can change the management of patients with hairy cell leukemia, because hairy cell leukemia is a very rare condition, and the standard treatment for hairy cell leukemia include chemotherapy with a purine analog, generally cladribine or pentostatin, associated with an anti-CD20 monoclonal antibodies currently available, rituximab. But in this treatment combination is extremely effective. So the majority of patients with hairy cell leukemia, if they need treatment, they will receive only one line of treatment, because after this treatment, the disease can can be controlled on long term. The issue here is that purine analogs are extremely toxic chemotherapeutic agents. With the chemo-free approach, and in the trial, we are exploring the combination of emurafenib, a BRAF inhibitor, with rituximab, the anti-CD20 monoclonal antibodies. We aim at achieving the same efficacy, because the efficacy of chemoimmunotherapy is almost 100%. Virtually every patient with HCL responds to treatment, but to spare patients the most relevant toxicities, including cytopenias that lead to an increased infection risk, and some infections may be life-threatening in this context. So we want to avoid the main toxicity associated with chemoimmunotherapy and still achieve long-lasting disease control.
Wonderful, wonderful. When will that study be completed?
We are approaching the end of recruitment. We almost achieved the target enrollment. So I just say that in the next, let's say, few weeks, we will complete the recruitment, and then we can have a first analysis of focusing on the toxicity profile of the different strategies. But we need more time in order to get insights in terms of efficacy, I just say.
So we'll have to have you back to report on the results of the
Hope
trial.
so. Thank you.
Hopefully, it's wonderful news. From your perspective, Lydia, what have been the most significant advances in recent years in the field of B-cell lymphoproliferative disorders that you focus on? And additionally, what opportunities and what challenges do you see at or just over the horizon? I know that cost is always an issue, and Italy has challenges just like Britain, just like America. Everyone's got challenges in the healthcare system. So, biggest advances in the last few years, biggest challenges, biggest opportunities. Three-part question.
Very hard questions. I mean, the great achievement we obtained in the last few years is that we got rid of chemoimmunotherapy. I think this was something we didn't even hope in the past, and now I just say in the last 8 years, I've never prescribed chemoimmunotherapy to my patients with chronic lymphocytic leukemia. So this is a great success from my perspective. Of course, we should try to understand how to use this, let's say, great power we got in terms of novel targeted agents, in order to use them in the wisest way, and allow all patients to receive the best available treatments. So we recently shifted from administering these novel targeted agents, as I mentioned, in a continuous way to define fixed duration treatment. And according to the most recent guidelines, we generally stick to the European Society of Medical Oncology guidelines. Whenever we have data and the patient is is suitable, we should prefer fixed duration combination instead of continuous treatment, because this is improving the management of health resources. This is improving the quality of life of the patients, and this allow us to reuse same treatment or similar mechanism of action once the patient relapses, because unfortunately we did not achieve yet in most lymphoproliferative disorders, and in particular in chronic lymphocytic leukemia, the cure of the disease. But we are getting closer, so the opportunities I hope we'll have in the future is by identifying other mechanism of action and combining them together, we will be able to achieve what is called undetectable measurable residual disease. So we cannot see the disease even if we use very sensitive laboratory technique, including generally flow cytometry or next generation sequencing. And of course, would be the first step to reach a cure, especially in CLL. So we have still a lot of work to do in the next future, luckily.
Well, if change continues at the pace that we have seen in the last few decades, I think you will achieve your mission. Finally, Lydia, a question that we like to ask all guests, a bit fanciful, but if you came across a magical genie and who granted you 3 wishes for your area of healthcare, what might those wishes be?
That's a great question. So, of course, if I could, I would ask for achieving the cure in CLL. But I mean, from trying to identify relevant improvements in my field, I would go first for equity in the access to the diagnostic testing, for example, because not all countries all over the world have access to diagnostics tests that are currently available in, let's say, the high income countries. And access to the novel therapies, because they are not everywhere available. If I could ask for something, I would ask for unrestricted, unlimited support to investigator-initiated clinical trials, because sometimes the company-sponsored have a different focus. Let's say, of course, in the end, they are benefiting the patient, but people working in the field with a research interest have key questions to answer, and I think that unlimited support for investigator-initiated trial would be key to achieve a further improvement in my field. And then for the management of the patient, I mean, we are trying to organize a multidisciplinary team that is managing the patient, the cardiologist, the psychologist, all people involved, because I think that this is benefit the most the patients. Seeing a team that is taking care of them and is providing different type of support, would be crucial for improving their everyday life and the quality of life if they have to live with a disease like chronic lymphocytic leukemia.
Wonderful. So I'm afraid that's all we've got time for today. I would like to thank you, Dr. Lydia Scarfò, for taking the time to join us and for everything you're doing for patients, everything you'll continue to do. And as I say, we must have you back on when that trial reports in the future. Thank you so much.
Thank you. I greatly enjoyed the discussion.
Well, I hope you enjoyed that episode of Hema Now, our bi-weekly podcast on haematology. Please consider subscribing on either Apple Podcasts or Spotify, or frankly, wherever you get your podcasts, so that you never miss an episode. Like us on social media, tell your friends and colleagues, and please check out the archives because they're growing if you've missed any episodes. And please join us again in 2 weeks for another episode. Until then, I'm Dr. Jonathan Sackier. I'm proud to be your host. Please, everyone, stay safe, stay well, stay curious. Bye for now.